Now we will learn about cerebrovenous anatomy. It is divided into three systems: superficial cortical venous system, deep venous system, and dural venous sinus system. That's a different thing. So the key principle is that venous anatomy is far more variable than arterial anatomy, and venous injury is often less forgiving than expected. First is superficial venous system. Let's begin with superficial cortical veins. These veins drain to cerebral cortex and subcortical. These drain the cerebral cortex and subcortical white matter. Most cortical veins ultimately drain into superior sagittal sinus through bridging veins. And during injury, when we get a subdural hematoma, these bridging veins are the cause of that subdural hematoma. The Regarding the supravenous system, main veins are vein of Trollard and vein of Labe, and the third one is superficial middle cerebral vein. Okay, so first we will start with the vein of Trollard. Yeah, so uh, this the superior anastomotic vein or vein of Trollard connects the superficial middle cerebral vein to this is middle cerebral vein. It will connect it to the superior sagittal sinus, and in some patient it is dominant superficial venous system. A large trollard may represent the primary drainage pathway of the frontoparietal convexity. Injury can result in venous infarction, postoperative edema, seizure, neurological deficits. Yeah, and from surgical perspective, that this vein often dictates the position of frontoparietal craniotomy. Next is the vein of Labe. The vein of Labe connects the superficial middle cerebral vein to the transverse sinus. This is one of the most surgically important cortical vein. This is particularly relevant during temporal craniotomies, pre-segment approaches, petrosectomies, subtemporal approaches, skull base surgery. A dominant vein of Labe may represent the primary venous drainage of temporal lobe. Injury may cause catastrophic temporal venous infarction here, and despite technically perfect tumor resection, still if there is an injury to or occlusion of the venous labe, that can lead to major venous infarct in the temporal lobe, and that we should recognize during subtemporal approaches. Even when we are planning for any craniotomies, and if there is any contusion, we need to be very aware of that about the vein of Labe, whether there is an injury to itself or not. And then is the superficial middle cerebral vein. This runs in the Sylvian fissure, and this vein demonstrates major anatomical variation. It drains it drains into cavernous sinus, sphenoparietal sinus, and through vein Lard and Labe to the superior sagittal sinus or transverse sinus. And understanding its drainage pattern often determine the site of fissure opening when we are dissecting the Sylvian fissure for various approaches. Then is the deep venous system. It is very important. Deep venous injury is often unforgiving. Damage may result in bilateral thalamic infarction, basal ganglia injury, coma, or death. So first we'll start with the internal cerebral vein. So this is the internal cerebral vein, and how it is formed. It is formed by the two veins. It is the by the septal vein and the thylamostride vein. What happens is the when inside the ventricle, this is the septum pellucidum. Here is a thalamus. If you are seeing in the ventricle, so thylamostride vein come from laterally, septal vein come from midline. They will join and make the internal cerebral vein. So these join and these make the internal cerebral vein here. Yeah. And the internal cerebral vein, it drains thalamus, caudate nucleus, internal capsule, deep white matter, choroid plexus. These veins travel posteriorly within the velum interpositum. Yeah, we will in the next video we'll see that image also. They are critically important during third ventricle surgery. Yeah, because in third ventricle when we are opening it, and it will be there. Intrahemispheric transcallosal approaches and pineal region surgeries. So this is very important. And next vein is basal vein of Rosenthal. So if you can recognize it, and then I will just tell which is the basal vein of Rosenthal. Just try to think. Yep. So there are two basal veins of Rosenthal. They will join the internal cerebral vein. Okay. And it receives drainage from mesial temporal structures, midbrain, insula, and deep sylvian structures. It courses around the, here are the cerebral peduncle. It courses around the cerebral peduncle and ultimately drains into the vein of Galen. Okay. So this vein is frequently encountered during interpeduncular approaches, ambient cistern surgery, basilar apex, and the aneurysm surgery. So we can encounter this at that time. And the next is vein of Galen. So we have this is the one of the most commonly misunderstood structures in neuroanatomy. The great cerebral brain or vein of Galen is not collecting vein for the entire brain. It is a principal outflow channel of the deep venous system. It is formed by the internal cerebellum plus the Rosenthal vein, and internal cerebral vein form this the vein of Galen. The neurosurgical relevance included in pineal region surgeries, vein of Galen malformation in kids where the kids will get heart failure because of this shunting, posterior third ventricle lesion, and in tentorial approaches. And any injury could be devastating because there's a it drains a lot of blood from the deep venous structures, and if there is an injury, it will lead to major bleeding. And then the dural venous sinuses, so that will include the inferior sagittal sinus, straight sinus, cavernous sinus, yeah, superior and inferior petrosal sinus, transverse and sigmoid sinus. So we'll go through one by one. So first is the inferior sagittal sinus. Sorry, this is the inferior sagittal sinus. So it is located within the free edge of the fox. So here is the fox. This fox is going like this, and this is the inferior edge where this is inside that inferior edge. And yeah, and when it and then is the then next is the straight sinus. Okay. Whenever I'm saying the name of the sinus, just try to think, and then I will mark where that sinus is. So this is the straight sinus. So how it is formed? It is formed by the deep venous system and falcian venous system. Okay. So deep sagittal sinus, vein of Galen, they form the straight sinus. Major landmark during tentorial surgery. Okay. So next is cavernous sinus. Okay. Two cavernous sinus on each side. Cavernous sinus is best understood as a venous plexus rather than a simple sinus. It receives from superior ophthalmic veins, inferior ophthalmic veins, and superficial middle cerebral veins, and it drains via superficial petrosal sinus and inferior petrosal sinus. Superficial and deep petrosal sinuses. Okay. And the superior petrosal sinus, the it drains at the junction of the transverse and sigmoid junction. Okay, also called as Dandy's vein when we are doing retrosig approaches. When we during the retrosig approaches, when we put a bar hole at the junction, and when we open it, and the first vein we use Dandy's vein, that is the superior petrosal sinus. um, then the inferior petrosal sinus will this will join at this sigmoid jugular. Usually it yeah it this is jugular bulb. It drains in the jugular bulb. So so this is important when the inferior petrosal sinus sampling is the gold standard investigation for ACTH dependent Cushing disease. And this is the transverse sinus, and this is the sigmoid sinus and the jugular vein. Yeah, and the sigmoid sinus exit the skull through the jugular foramen. Yeah, forming the jugular vein. So the dominant transverse sinus is usually the major determinant of venous outflow. Before any posterior fossa or skull base operation, dominance of the transverse sigmoid system must be assessed. And yeah, and other importance of these sinuses is the or deep venous system and the other systems is when we get the sinus thrombosis. The sometimes we can get central sinus thrombosis or transverse sinus thrombosis, transverse sigmoid or sigmoid sinus thrombosis. If it's on the dominant side, it is catastrophic. And yeah, so then that we need to see from the radiology. Yeah, that's it. We'll Thank you.